Okay, so welcome this evening. My name is Rep Boucher. I'm one of the co-chairs for the Neuro IR service line for the resident fellow and student section of SIR. And I'm really excited for this presentation that we have this evening. It's going to be on the endovascular treatment and management options for intracranial aneurysms. And the speaker is Dr. Boo, coming from West Virginia University, where he is the associate professor of neuroradiology and interventional neuroradiology. He's also the Associate Stroke Director for Endovascular Therapies, and he's the Radiology Residency Program Director and Vice Chair of Education for the Medical School at West Virginia University. So we're very lucky to have him be able to talk to us tonight. And without further ado, I'll go ahead and pass it over to him so we can get started.
Thank you, guys. I really appreciate you having me on here. I think it is a great educational tool that you guys are using with these webinars, and I'm encouraged by the radiology residents who are interested in learning more about IR, and in particular for me, neuro IR. It's something that I did not know that I was going to get into as a medical student, but I was drawn into the interventional world after the match. Actually, I was thinking some other procedural field, and then my last elective as a medical student was in IR, and that was the first time I was exposed to it as a fourth year, and discovered a field that I never knew existed before. This was like in 2004, 2005-ish. And from that point on, I was hooked. I knew I was wanting to do something in intervention. And then during radiology residency, I got drawn into the neuroradiology and the neurointerventional world. But thank you for having me. I'm going to share my presentation here. So hang on a second. So as I said, my name is SoHyun Boo. I am the residency program director at West Virginia University, WVU Medicine. I am in the departments of radiology and neuroradiology. We are an interesting program where we have both a neuroradiology department as well as a radiology department. I'm the stroke director for endovascular therapies there, doing neurointervention. So I thought I would give a presentation on what I call bespoke aneurysm care, a tailored approach to endovascular neurointervention. We're going to be discussing aspects of aneurysm treatment and how things have changed over the years. As I'm sure everyone is aware, radiology and interventional radiology is continually evolving with the technology that we have. These are my disclosures. It's not relevant to my talk today, but I said bespoke aneurysm care. What does bespoke mean? It's talking about, for example, custom made, like a bespoke suit, or dealing in or producing custom made articles, like a bespoke tailor. So why am I talking about that? Well, for example, if you have a poorly fitting suit, it looks sloppy. It doesn't look the greatest. Compared to a nicely fitted, nice fitting suit that's been tailored to you, makes you feel confident, makes you feel strong. My wife, I think, made me choose this actor as the model for this. But what does that bespoke tailor do? They fit that suit to you as an individual. And I think, what we do in aneurysm treatment for neurointervention is just that. We try to fit the right type of embolic device to that patient's aneurysm, because not every aneurysm looks the same. As we know, every patient's vascular anatomy is different. And so we really have to, when we plan out a case, think about how are we going to treat this patient individually. And technology has made its way to where we can at least semi-customize, the treatment for that patient. It would be great in the future if we could on the fly 3D print or do something specific to match exactly what that patient needs. But at least for right now, we have multiple different types of devices that we can try to semi-custom fit to those people. So just as background, you may have already, learned this before, but just we're talking about intracranial aneurysms. What is that? Well, for whatever reason, there's a weakness in the wall of the blood vessel, and so that blood vessel wall enlarges or pooches out and forms this aneurysm. Prevalence in an autopsy series generally is quoted somewhere between 0.4 to 6%. On an autopsy series, that equates to about anywhere between 1 to 18 million persons in the US will have or will have a brain aneurysm. So in general, we kind of say there's about 2% of our population that has a brain aneurysm in someone who doesn't have any other risk factors really. And the incidence of aneurysmal subarachnoid hemorrhage is about 10 per 100,000 person years. So, it's not that common, it's not that rare, but it is a disease certainly that has really affected, obviously many people we know, potentially within even our own family and friends who had a brain aneurysm, whether they were ruptured or incidentally found. This is actually, unfortunately, a patient of mine that we did a post on who had this basilar aneurysm here. We treated it. That basilar aneurysm actually has coils and a flow diverting stent within. And unfortunately, on like post-op day 4 or something, had a re-rupture basically, or so we thought, re-ruptured her aneurysm and died. We went to the autopsy and I examined her vessels and was actually surprised to find that the aneurysm was intact and thrombosed with the coils and the flow diverting stent. What was surprising was there was actually a different tear or hole in her basilar artery. You can actually see this white, this is atherosclerotic disease actually, and right adjacent to there was a defect in the vessel wall, and for some reason or other this occurred in a subacute fashion where basically a dissection led to bleeding, hemorrhage, and ultimately death. So if we think about the history of aneurysms, we can go all the way back, 2725 BC. There are papyrus papers where Imhotep describes an aneurysm. Hippocrates described apoplexy. Galen coined the term aneurysm in AD 180. So, you can follow this timeline as intracranial aneurysms were described, then treated with ligation. For example, in 1885, Horsley ligates the carotid to treat an intracranial aneurysm. But really, Dr. Cushing then has a silver clip in 1911. And in 1927, Moniz performed a cerebral angiogram. And in 1937, Dr. Dandy has the first clipping of a cerebral aneurysm. And it wasn't until 1990 then when the endovascular coil was developed, the Guglielmi coil. And since then, I think the technology has just continued to grow exponentially. But we get to about 2002 when the ISAT trial came about. And in 2003, the ISUIA. These two, I think, trials are some landmark trials that really altered the landscape for neurointervention. Why? Because, well, the ISAT trial was a study that was looking at basically coiling open surgery versus clipping, open surgery clipping versus endovascular coiling. And in that study, basically, it was showing that coiling had a better outcome clinically than clipping in someone who had a ruptured brain aneurysm. The mortality, morbidity was lower in someone who was treated endovascularly in a ruptured aneurysm scenario. So I think that, that right there is awesome. I mean, that really said, look, someone who comes in with a ruptured brain aneurysm, in all manners that you can try, you should try to go for endovascular treatment. The ISUIA trial, that also was very important because that was something that looked at unruptured aneurysms and really gave us a better understanding to the natural course and history of brain aneurysms. Really, it helped kind of let us try to estimate, well, what is the risk of rupture in somebody who has an aneurysm that is found incidentally? More and more imaging is done today, right? Everyone is getting a scan. And so we're just discovering these aneurysms incidentally. They're getting a scan for some other reason. And it's, oh, by the way, you have a brain aneurysm. Well, now what do you do? And so this ISUIA trial was something that allowed us to try to come up with some estimate to their risk of rupture. And that really said that small aneurysms, in particular those under meters in size, not considering any other risk factors, actually had a pretty low risk for rupture per year. And so obviously, as these aneurysms do get bigger, your risk does increase, but really, overall, a lot of these aneurysms that are considered small were typically thought to be benign, these incidental ones. And so we also see that, location obviously matters. This study was showing what other risk factors, in particular, the greatest risk factor is, have you ever had a previous aneurysm rupture or not? So anyways, these two studies really, I think, further developed the endovascular field for neurointerventionalists as a whole, and has continued to evolve. What else has changed for us? Well, I mean, technology, like I said, it continues to grow, and that technology can grow in imaging, in access to these brain aneurysms, and talking about catheters and guide catheters, sheaths, things like that. The embolization devices that we use, we started with these detachable coils, which we certainly still use today, but there have been, more advancements in stents and balloons, for example, to treat more types of aneurysms of different morphology, different parent vessel morphology. And so these advances in the embolization device is allowing us to treat more and more aneurysms. And then again, customization. The fact is, because we have improvements in access, improvements in embolization, it's allowing us to better customize our treatment to that patient. So what is it in neuro IR that, a bit or different compared to body vascular IR? Well, typically we are going to be using DSA, which is the same, right? We're using digital subtraction angiography in IR. But the imaging technology, for example, we definitely use 3D rotational angiography a lot. We use biplane angiography. So in neuro, the biggest difference, I think, is the fact that we're pretty much using biplane angiography for neurovascular intervention, because it allows us to really orient ourselves in space, the vascular anatomy, in at least two planes, to then orient ourselves in our, in 3 dimensions. But this technology allows us to then, again, from a classical perspective, coil an aneurysm like you see here. And that technology in imaging just continues to grow, giving us better quality images. This is also what's called a roadmap, right? Everyone is familiar with. The quality of the roadmap has improved over time, just allowing us to more easily and safely access the aneurysm to treat with our imaging capabilities. And speaking of access, okay, that also has improved. I mean, literally from when I was a resident to a fellow. So, when I was a senior resident in radiology, I graduated in 2010, and I was seeing coiling, I was seeing stroke thrombectomy, to then, I went away and practiced general radiology in the military, in the Navy, for about 3 years, because I had to pay back that time. But then as soon as I paid what I owed, I knew I was wanting to do neuroradiology, neurointervention. I come back and do a fellowship 2013 to 2015. And, in even those 5 years from graduating residency, things were changing in terms of access. The guide catheters, the intermediate catheters that we use were getting better and better in allowing us to gain more supportive, stable access in order to then deliver our microcatheter or the devices from the groin all the way up intracranially. And then what else has changed, relatively recently is radial access, right? We're doing more and more things from a transradial approach. So all these devices have improved in our access in order to treat these aneurysms. I give this example, I think, when I've given talks to other people, just to give an idea of the size of these catheters that we're using. If we're more familiar with potentially pasta and musical instruments. And so this is just an example for example, a typical glide wire that we use, an 035 glide wire is like the size of Capellini, or the micro wires that we use, we might, in neurointervention, we typically use an 014 micro wire. That's the equivalent to about the B string on a guitar, for example. And so again, embolization devices have improved. We're using biplane angio to orient ourselves in 3D and deliver, whether it is something like detachable coils that you see here. That was our classic type of embolic device. And what are we trying to achieve here? We're trying to pack an aneurysm with these coils and pack it as much as possible so that we can get thrombosis to occur in this aneurysm. And the coil technology, improves to where they're trying to make what is essentially platinum wire typically to coil and to, seek out empty spaces and fill in these little spaces. But that platinum wire can only, bend on itself so much, limited to its own physical properties of the metal. But ultimately, we're trying to pack these aneurysms as best as possible. But these coils can only do so much. Number one. Number two, we can pack an aneurysm as much as we can. We can, use these soft coils that are trying to fill in all the little empty crevices. But at its best, maybe we get 30, 40, 50% packing density of an aneurysm because there's still a lot of space in between the loops of the coil that the coils can't fit into. And so, people have tried different configurations of coil design. They've even tried, say, adding hydrogel, some biologic in between the coil loops to provide more packing. But all that is, continue to grow, but it reaches a certain point where I think you're again limited by the physical nature of the coil, the metal in the coil itself. What other limitations do we have? Originally, we're putting these coils inside of a typical Berry aneurysm, a narrow neck saccular aneurysm. But what happened when the neck became wide, right? The opening of the aneurysm is if that was wide, if the neck is wide, how do you keep those coils to form itself in the aneurysm and not come out, not herniate out into the parent artery, and obviously then be a nidus for thrombosis, for embolism. And so further technology, developed in the formation of intracranial stents. And so we have different types of intracranial stents, for example, which provide a scaffolding, so to speak. It provides this support within the parent vessel that is, for example, big enough in the cell size to allow a microcatheter to go through and deliver the coils, detach the coils. The coils themselves are too big to go back out of the stent. So the coils are formed inside the stent, and then you can slip that catheter out, and then the stent endothelializes and heals in. So, these intracranial intracranial stents allowed us to start to treat different morphology of aneurysms where the neck was wider. What else occurred? Well, then we started to develop flow diverting stents. So if I look at these intracranial stents, typically you think of a sheet of metal, and a lot of these are made out of nitinol, which is a nickel titanium alloy. This type of nickel titanium alloy, the nitinol has memory to it, initially developed by the military, but they take this memory metal, laser cut the cells, the structure of the stent, roll it into a tube and put it together. And then, it's put inside of a catheter. And then when it comes out of the catheter, the memory metal remembers the shape that it was supposed to go back to, the diameter size it was supposed to be. And it does that. But later we have this technology where we developed braided stents. These are stents where instead of a sheet of metal that's cut into the cells and rolled in a tube, these are threads of metal wire, that are woven together, braided together to form a stent. The difference really is these braided stents then have a much higher metal count and has much less porosity. And so the cells here are very much smaller. You can't fit a catheter through it per se, but the concept is completely different. The design of this is if you put a flow diverting stent in the parent artery across the neck of the aneurysm, it hinders the blood flow going into the aneurysm so much because of the porosity is so low. The aneurysm thromboses because the blood flow is static inside that aneurysmal sac. So no longer are you trying to fit a whole bunch of coils inside of these bigger aneurysms. Now you're really just trying to fix the parent artery itself without needing coils. If you can, basically treat the parent artery by laying a flow diverting stent in, that endothelializes in, thereby the endothelial layer heals all the way across, covering that neck of the aneurysm, and it blocks the flow in. Other devices then that occurred from that braiding technology would be something like this, which we call a intrasaccular device, intrasaccular flow disruptor, as opposed to a vascular flow diverter. So these intrasaccular flow disruptors are designed, again, if they sit at the neck of the aneurysm, and so we're not really necessarily trying to fit it exactly to the whole size. What we're really trying to fit this somewhere that blocks the neck of the aneurysm. And again, the porosity is so low through that area that whatever blood that seeps in through into the aneurysm is static, it's stasis inside of that aneurysm sac, and thereby thrombosis. So, we have these newer devices that allow us to pick and choose what would be a better scenario to use depending on the patient's anatomy, depending on the morphology of the aneurysm. And it doesn't mean necessarily, though, that it just replaces coils. We still have multiple different tools in our armament, to choose from. And this is a patient, for example, that I still utilize coils in, that has a wide neck aneurysm. I would have loved to use something like a intrasaccular flow disruptor and just put that right here at the neck of the aneurysm and not have to, put a bunch of coils in. But this patient had a documented nickel allergy, and a lot of our stents are made out of nitinol. Like I said, they have nickel in them. A lot of flow diverting stents have nickel in them. And so I was limited in this patient in utilizing any sort of stent to remodel the neck and allow me to put coils in. And so what did I have? Well, we also have balloons. We can do balloon assisted coiling, where I can inflate a balloon across the neck of the aneurysm temporarily. It's enough to basically allow me to, at the same time, have a catheter inside the aneurysm to deploy these coils, which take its shape and form inside that aneurysm and hold itself there, so that when I deflate the balloon, they've already taken its shape and are stable in that aneurysm, and I don't have to leave a stent in someone who really can't take a stent because of their nickel allergy. So all these things, is what goes into planning the treatment on a patient. What am I going to use? What is going to be the best device? Do they have an allergy, for example, to nickel, or are they somebody that I necessarily want to use additional devices like stents in, which means they're going to be put on dual antiplatelet therapy. And so all these things I take into consideration. This shows you, for example, the difference in amount of metal that's going into a patient depending on the type of stent that we're putting in. So those original nitinol stents like Enterprise and Neuroform, which is just laser cut from a sheet of metal and rolled in a tube, those had low metal coverage. There was in general about 6% metal to artery in general. And so, they need some dual antiplatelets, but not for very long. It's going to endothelialize pretty quickly. The amount of metal there that's altering the endothelium is not that, not that great. Versus when we start putting these flow diverting stents in, which have much higher metal to artery ratios, 30, even up to 60% for an intrasaccular device like the Webb. So, sometimes these patients, for example, that have a flow diverting stent like the Pipeline, they're on dual antiplatelets for 6 months, typically. So things like that, I had to think about whether or not I want to put somebody or use some kind of device like that and put somebody on dual antiplatelets for that period of time. The Webb device, the intrasaccular device, is actually nice in the fact that since it is only going in the neck of the aneurysm and not putting metal across normal endothelium, you actually don't need to have dual antiplatelet therapy. So again, that's something that I would consider in a ruptured patient, for example. When someone has a ruptured brain aneurysm, one, they're coming in emergently, they're not being pre-treated with aspirin and Plavix before the procedure. They came in unexpected. You're treating that aneurysm in someone with a subarachnoid hemorrhage. I'm not going to really want to put them on dual antiplatelets. I'm not going to want to load them up with dual antiplatelets before the procedure and keep them on them for 2 months or 6 months in someone who has an acute ruptured brain aneurysm. So all those things play a role in what am I going to use to fix this aneurysm, whether I can use a stent or not use a stent. These are just then more examples of where we customize the devices used. In this patient, we have this very large aneurysm. We used both a combination of coils as well as a flow diverting stent. We obviously didn't have to pack this aneurysm as much with coils because that flow diverting stent is really doing the main job of thrombosing this aneurysm. We have imaging technology, again, to really allow us to see our devices. Here, this was a very shallow, very what we call a blister aneurysm. You can barely see where the vessel wall, it got paper thin and pooched a little bit and ruptured in this patient. There was really no other way to treat this patient endovascularly or really even open surgically other than putting in a flow diverting stent across this disease segment of vessel where the blister aneurysm had bled. And we lay this stent just across there. And in this scenario, we were forced to use dual antiplatelets despite the rupture. But again, we can see how this can help us fix an aneurysm that is barely even perceptible, where there's no way you can fit a coil inside of. Another patient here had actually multiple aneurysms, one involving the basilar artery, and we were able to kind of a sidewall aneurysm. So we were able to lay one of those stents in that basilar to allow us to then just keep those coils in that sidewall portion. We have the other part of that patient's aneurysm in the anterior circulation involving the internal carotid artery. Again, a very large, just blown out carotid that we're putting a flow diverting stent within that blown out portion of the carotid, loosely putting in some coils to help the thrombosis process. But again, majority of that thrombosis is occurring because of this flow diverting stent that we've placed. And this is a patient who, did very well and actually was, I think, a pediatric patient, like 13 years old. When we treated her, she's, currently in, I believe, PT school now. And then here is another example, again, choosing something to fix this ICA terminus aneurysm, wide neck. I'd rather not put a flow diverter here and cover the ACA. I'd rather not put a stent here and coil, and again, cover the ACA or something if I put the stent in the MCA. So what could I use? Well, we have that intrasaccular device, for example, which again, even if the aneurysm is real ugly looking like this, I'm imagining how can I fit this intrasaccular device where it just covers that neck. And in this patient, then we use some of these pearls of, you measure, you get good imaging, make sure you're fitting the right size device in. We have the proper access, whether it's using triaxial techniques of putting a guide catheter, putting an intermediate catheter inside of that, and then your microcatheter, or just coaxial. We can use a steamer even, right? Sometimes we steam shape our catheters to really fit inside that vessel anatomy better. Slow and steady wins the race. We utilize, I think, nice steady movements because you're trying to control something so distal from where you are at the groin to the head with all the tortuosity in between. Your devices, your access devices have made the steps easier and faster to get there. But once you're there, you want to be nice and steady with your actual devices themselves. We get comfortable with hands apart, hands together, being able to manipulate the microcatheter and device with one hand at the RHV, or while your other hand is kind of manipulating where your microcatheter sits during that. And then we utilize many times flat panel CT, called DynaCT with the Siemens, Vaso CT and Philips, I believe, LCI with Canon, Toshiba's. But with this type of ICA terminus aneurysm, I'm trying to fit an intrasaccular device in there. We're going to measure out accurately. We're going to then go and try to put this device in here, for example. And I'm just showing this to say, access number one. Here I am trying to deliver this intrasaccular device through the microcatheter in the aneurysm, and on this view, the catheter is sitting okay, but on this view, it's really off to the side. And I'd be worried that this device is just going to really push on the side of that aneurysm before I can really get it open where it is safer. I'm worried that this is just going to perforate and rupture that aneurysm itself. But I'm trying. I'm seeing if I can get it to take shape there as I'm delivering this microcatheter. When I talk about hands together, hands apart, this is where I'm using the hands apart method of I'm controlling my microcatheter with my left hand, kind of controlling where its position is, how much pressure is going on, while my right hand is doing the unsheathing, all with just one hand. I'm unsheathing it, I'm delivering that device all from the right hand, while my left hand controls how much pressure is on that microcatheter. But ultimately, I wasn't able to deliver this because my access was not good. And fast forward here, couldn't get the access good, and the device just would not stay where I needed to stay. So we steam shaped the microcatheter, and this was actually several years ago. Currently, they make catheters for this device that are already pre-shaped, in a 45 or 90 degree angle. But at this time, I had to steam shape it and see how much better the catheter access is within the aneurysm. I'm already starting in a position as opposed to the previous position that you can see on the prior roadmap. My catheter is sitting in a much better position now. Now, when I deliver this device, I can get more of it out in a stable position to where it's going to want to stay there. And as I just continue to fast forward, the device comes out, and now we have this intrasaccular device that sits right at the neck of the aneurysm. It looks positioned well. We do a DynaCT to, again, visualize these things, using our imaging technology to be able to see the device better. because of the amount of metal that is braided here. Normal routine 3D angiography does not work. So we do that and customize this device to this patient. So I end with that. I thank you guys for allowing me to talk. I'm happy to try to answer some questions. I think Red or somebody will hopefully be able to see questions on the chat and moderate or take any questions like that. And I'll end it there.
Awesome talk, Dr. Boo. Really good stuff. I really like the stuff about the bespoke neurointerventional treatments and how everything is tailored to each unique patient. And I think, you have a really unique toolbox to choose from for the different treatment options. And I think that's one of my favorite things about IR is just kind of tailoring treatment. And each patient is a different problem that you need to solve. And so one question that we had come through the chat is, what intervals are you using for patient follow-up, and how long are you following them for? And then what imaging modalities do you prefer to use for the follow-up?
So typically I would do, a cerebral angiogram, catheter angiogram, after endovascular treatment of an aneurysm. I would do a catheter angiogram, usually at 3 months if they were a ruptured patient, versus 6 months in an unruptured patient. Because catheter angiography is the gold standard, that first follow-up, I want to see, is that aneurysm truly thrombosed? Obviously, a CT scan generally is not going to show you, a CTA is not going to show you what you need to see because of all the metal artifact. So that first follow-up imaging, I'm going to use catheter angiography. Generally speaking, if that looks like, what I want it to be, the aneurysm is thrombosed, everything looks good, then I will go to pretty much annual MRA follow-up. We do on post-coilings or post-treatment, we do a MRA intracranial with and without contrast, because you can certainly see some, residual filling if there happens to be any with the contrast over just a routine non-contrast time of flight.
And then a next question is, so for the ISAT 2003 trial that you mentioned, the size criteria, I think it was 7 millimeters. There's less than 1% chance of rupture. Did it mention, or do you use other morphological features that would kind of point you towards treating a certain aneurysm, as opposed to just watching it?
Yeah, so that was the ISUIA trial for incidental aneurysms. These are for unruptured aneurysms. It said small aneurysms, typically under 7 millimeters, had a pretty low risk for rupture. Those aneurysms that were bigger, that percentage increased per year. Other risk factors like hypertension, hypercholesterolemia, smoking, diabetes, also increase, your risk of rupture. Genetic, if you had a first order relative like your parents or your sibling that had a ruptured aneurysm, then your risk also probably went up some. And then certainly the morphology and the location can vary that risk. And I do, if you have just a smooth walled spherical aneurysms, probably not as bad as something that has, multilobular, other bunch of little blebs hanging off of the main dome of the aneurysm. You worry that those are weaker points in the aneurysm itself, even if the aneurysm may be 7 millimeters or 6 millimeters. And so, we still don't understand completely, because even though we had this ISUIA trial that said small aneurysms less than 7 probably have a lower risk of rupture, but then it's like, I'm coming in to treat this ruptured aneurysm, and how, we're measuring it, it's 4 millimeters or something like that, right? And so it's like, obviously, there's more to it than just size. There's more to it. Why does this aneurysm rupture, and this other patient that has a 5 millimeter aneurysm that we've been following conservatively with annual MRAs for the last 10 years, nothing's going on, right? So we don't understand it completely. We obviously, again, as I think, that's what I think is great about interventional radiologists interventional neuroradiologists, what are we, our background is imaging. And so, we understand that, look, we can look at MRA, we can do vessel wall imaging is what people have started to do to try to even get down even, closer to the vessel to see, is there something going on in that wall that is making this aneurysm more prone to rupture with inflammation or something happening in that vessel wall. We try and understand that with, for example, vessel wall imaging. So yeah, I mean, we don't understand completely the ruptured aneurysm that comes in that we're measuring 4 millimeters. We don't actually know what it looked like before it ruptured. Who knows? That's the other thing. So there's still a lot of stuff out there that we're trying to study and understand.
Awesome. And then I could ask you questions all night, but one more question that I have is, I know that different aneurysms will, have the treatment types indicated. But if you had an aneurysm where there were multiple treatment options available, do you have one preferred technique that from your experience, that you just have found that they have less complications, or they're just kind of more effective? Like, from your experience.
No, not necessarily. I mean, when newer devices kind of come out, they're generally going to compare themselves to the traditional ways, right? And these newer devices get approved because essentially they're proving that they are just as safe and just as effective. They don't necessarily prove that they are better. So I can't really comment. I don't necessarily think, oh, I want to do this because I think it is safer necessarily as something else. I think the safety is the same, or that's at least, when the trials for a new device to get FDA approval, for example, is done, one of the main things that they're going to use to compare itself is this new device as safe as what we've had up to this point, whether it's, comparing it to clipping or comparing it to coiling, let's say. Certainly though, what device I use, I am going to favor something depending on whether, for example, am I talking about a ruptured aneurysm or an unruptured aneurysm. That number one, I think, is the first thing that I think about when I'm dealing with the aneurysm. Is it ruptured or is it unruptured? It completely changes everything, because the ruptured aneurysm, again, I'm going to try to avoid having to use dual antiplatelets. So that pretty much limits you from the get-go as much as possible to just standard coiling or balloon-assisted coiling or a intrasaccular device like the web. Because in those three scenarios, I don't have to use dual antiplatelets. In a unruptured scenario, then it's a different game. I have any choice of those three that I just talked about, plus stent-assisted coiling or flow diverting stents, because I can plan that out. I can say, hey, we're going to put you on aspirin Plavix for like a week before the procedure to make sure that your body is primed to receive a stent that's going to be sitting in your vessel that alters the endothelium, and we don't want that stent to thrombose. You're going to stay on dual antiplatelets for anywhere from 2 to 6 months potentially. So that really does change things. What about these newer devices like a flow diverting stent, like a intrasaccular flow disruptor? The one thing that is kind of nice about those compared to coiling, let's say, is usually you're talking about putting in one device and you're done with the treatment. So it is possible, it is not uncommon that the case is shorter when you're using a flow diverting stent as a treatment or using an intrasaccular device as a treatment, because once you deploy that, that's kind of the end of the case, as opposed to putting in a coil, putting another coil, especially on a big aneurysm. Like you could have, let's say, a 10 millimeter aneurysm, and you might be putting in 12, 15, 20 coils. And so, that is like let's say a 2-hour case versus that 10 millimeter aneurysm, I could conceivably just put one flow diverting stent and be done, within 30 minutes, or put a intrasaccular device if that's what it, can take, and again, be done, probably within 30 minutes. So there is benefits from that perspective of some of these newer devices of treatment that are, different from coiling.
Awesome. Thank you very much. All right. Well, it looks like you've answered all the questions. So, yeah, I just want to thank you very much for coming.
Yeah, one
And,
thing I just want to add again, I'm always I'm passionate of the fact that I'm a neuroradiologist, that's doing neurointervention, and for everybody out there who is either interested in that or is interested in body vascular IR, we're the originators of this. I want to encourage you all that are wanting to do intervention, great, and keep up the passion for it. Don't let, basically don't let some surgeon or whatever say, no, this is like our thing. No, we know that this is what we do day to day, and we're better at it. And I want to just encourage you guys to keep at it. And even in neurointervention, right? Most of the time, yeah, you think, oh, this is neurosurgery now, or even now neurology is getting into it. But for example, at our program, it is all neuroradiology run. I am the stroke director for Endovascular. We dictate what happens for all aneurysms. I mean, I treated 60 brain aneurysms last year. That's like unheard of, I think, in a lot of places. So it's a matter of being good at what you do. You're going to learn what you do to be good at it, and you be good at it so that you stay relevant, and then people are going to come to you regardless.
Love it. It's inspiring, and I think that's a great way to end it.
Thank you.
Yeah, thank you.